Okay, guys. So with this, we complete this chapter. So our chapter was instrumental dose and dosing interval, and I think by this you got a better clarity. How will you, when you see now any kind of any kind of drug, any kind of like narrow therapeutic index or wide therapeutic index drug, a patient is involved. I think you will get better insight now. How the dosing interval might have been fixed, or how the dose is fixed. You see in case of drug like digoxin, they start from like they sometimes they also give 2 times weekly, 3 times weekly, okay, depending on the case. So there are like variety of regimen you will see, you will come across, but your job as a clinical pharmacist is to understand and the fundamentals lying behind them, okay. Though the practicing clinician might not have like um, might not be completely aware of this kind of thing, but you should be knowing this, okay. You should be knowing the kinetic behind this, okay. So what's the kinetic involved in having that much wide variety of dosing regimen for a same drug or for a different drugs. So I think you got better clarity, isn't it, with this chapter about dose and dosing interval.
Yes, sir.
That is why I kept this chapter after TDM, because I was knowing the Cmax, C minimum, C average may come, and if you have read the TDM already, it might help you here. So that's why after TDM only I covered this. Okay. Yes. What? Anybody have any doubt? What doubt you have, Sarath? You're telling you have some doubt.
Sir, about the tapering of doses, sir, like chronically we are giving some drugs. We know the therapeutic concentration also. Like while tapering, the CSS will be reduced. How should we calculate this?
How to?
How to calculate the dose required for tapering? Like steroids only, if we take, we have to reduce like 3 days once. Like
Mm-hmm.
this dose on this for these three
See,
days, and then again reduce.
See, now, first of all, there is two things. One is tapering. Next thing is CSS, okay, or CFS. So, so here, I mean to say, we are talking about dose and CFS. So here in dose side, you are talking about tapering, okay. And now we look what is happening to CSS, or what we desire from what CFS we desire. So here, what is the purpose of tapering first? From tapering, and you have to understand what is the purpose of tapering, because we don't want the drug concentration to get dropped suddenly, okay. Because if it happens, and the dynamic parameter, maybe from receptor point of view, or maybe from um, some other dynamic parameter may fluctuate a lot, and the patient will have exaggerated response, or some kind of side effect, withdrawal symptoms, all those things. So keeping all those things in mind, we go for tapering, okay. So but the ultimate goal of the tapering is to decrease the drug concentration, that is decrease the C average. At the same time, if we don't do the tapering, the C average is going to drop very quickly. Our main goal of tapering is to decrease the C average, but not suddenly, but to decrease the C average. Okay, so here it's not like calculation. Okay, we know that the patient was, there is no particular formula to calculate how to calculate the tapering this thing. There are set of regimen, again based on experiment, I can say, several experiment, and then okay. This drug can be tapered following this protocol, like that protocol has been designed based on the serum concentration. Again, this is really advanced studium, okay, about tapering, I can say. So so if so tapering here, the ultimate goal is to reduce the C average, okay, but not suddenly. So since you are reducing the dose, definitely C average is going to reduce. But as of now, I haven't come across any formula where we can calculate the C average. Sorry, the tapering dose. Okay, this is again advanced kinetic. As I told you, you should have many. For example, in this chapter only, I think most of the things, most of you, in most of your mind, what might be going around is, come on, we read this much interesting fact that okay, how to calculate the dose and dosing interval, but we can't do still. I but we can't do still because why? Why? Whatever I am teaching,
Practically.
why you can't do? You have understood the concept, but you need some other values in this equation. You know, you can easily do it. You can easily calculate the tau here from this equation if you have all these things, right? So you can do means it's arduous to do. That means you have to find the C max and C minimum for that. Based on some other value only, you can do frequency and dosing interval calculation. Okay? If you don't have, if you simply have a drug, okay, and you don't have any other parameter, then you cannot. Okay, it's difficult. You need to have a t half. You need to have some other kinetic data, and it's not like you cannot get it. If you do the literature review, definitely you will get it. There are plenty of the resources giving you this data. So what I'm telling is, if you are involved into the subject practically, when you go in the TTM center, this kind of thing, it will be easy to do. Okay, when you are working in the TTM center. So the ultimate goal is to reduce the dose and reduce the C average, but not suddenly. That's why we taper it. Okay, so I hope that addressed your queries to an extent.
Yes, sir.
Okay,
Good.
so anybody else have any doubt?
Sir, one more thing, sir. Like
Yeah.
for different indications, we have different doses for a particular drug, no, sir. So
Again,
will
yeah.
CSS also same? Sir? Like,
yeah, again, this is what I think in the beginning only I had told. When we are now, when you have read the kinetics, when you talk about those, there should come in your mind about C average. Okay, you should thinking about C average or CSS. When you think now, when you think about, and in the beginning I told you there are there are many indications of the same drug. Why we have many indications? Because we need many C average. Like we need different C average for different disease. For example, aspirin in rheumatoid arthritis, we need different C average. Okay. For example, aspirin in the same as a maybe antiplatelet, we need different C average, because at that C average concentration, this effect we are getting dynamically. So definitely the dose has to be different for the same drug for different indication, because we need different C average. This is what you wanted to ask?
yes, sir. Got it.
Okay.
Thanks.
The response you are getting at receptor level, at the dynamic level. Anybody have any other doubts? Anybody have any other doubts?
No, sir.
No doubts. Okay. So the next
No, sir.
today is I think Thursday, right? Thursday. So next Saturday, like coming Saturday and Sunday, we'll wind up this chapter. Okay. So with this, we'll complete our syllabus.